Hi, very good evening. So today we shall have this textbook discussion on the topic bleaching. Okay, so we'll be following Grossman. I have shared a few images of the text which we are going to discuss today, and you can just follow that simultaneously while we are discussing. So today we'll focus only on textbook discussion. So the same topic MCQs will have a separate session, right? Not today, tomorrow, day after tomorrow, whenever possible. So I hope you're able to follow what I'm saying and also try to maintain a hard copy if possible or at least a soft copy. Along with that, have a notes, right? So that you can make a note of various key points which we come across in the process, right? So, hi everyone, a very good evening once again. Hi Bernice, hi Ashina, hi Srish, Mega, Neetu, Pooja, Prithvi. Hi Fauzia, hi Regina, hi Komal, Sahiti, Alvin, Zina. Hi Niharika. Yes, Devana. Hi Richa. A very good evening once again. Right. So we'll just start with our textbook discussions. I'm following 13th edition and page number 499. Okay. So as a starting point, hi Mini. So we have discussed about this types of discoloration or types of staining in one of the videos, if you remember, in additional points in operative dentistry or one topic. I have uploaded that recently to e-classes. I have discussed about different classification of stains like intrinsic and extrinsic, exogenous and endogenous. So we have different categories with examples, right? So we'll not go into details of these discolorations, but we'll just focus on key points pertinent to these discolorations, and then we'll proceed with the bleaching, the core topic for today's discussion. So if you observe page 499, is mentioned the normal color of teeth. So the normal color of primary teeth is bluish white, and the color of permanent teeth is grayish yellow, grayish white, or yellowish white. And obviously, in case of old age, the teeth appear more grayish or yellowish compared to their younger counterparts. And also remember, milk teeth are called so because the refractive index of tooth of the deciduous tooth is almost similar to that of milk, so they're called as milk teeth. And along with that, we have this Nathu's classification for extrinsic discoloration based on the ability of a chromosome to cause a discoloration. So Nathu's classification, we have N1, N2, and N3. N1 is a direct type of stain, N2 is also direct type of stain, whereas N3 is indirect type of stain, where we have something called as pre-chromosome. So N1 type or direct dental stain, the colored material, that is chromosome, binds to tooth surface and causes discoloration. And the color of the stain is same as that of the color of the chromosome. So the color causing substance, that is chromosome, or the color which it causes to the tooth, that is a stain, both are same in case of N1. All those are categorized as N1 type of stain. Whereas N2 type of stain, the color of the chromosome and the color which it produces on the tooth, that is staining, is quite different. So N2 type or direct dental stain, the chromosome changes color after binding to the tooth. And N3 type or indirect dental stain, where we have something called as pre-chromosome, which is colorless, but on binding to tooth, it produces a color, right? So we have this Nathu's classification of extrinsic discoloration, N1, N2, and N3 types of dental stains. And also, there are various causes for discoloration, as you're all familiar with. It can be extrinsic, it can be either medication, or it can be various elements, or it can be even trauma. And there are numerous causes like trauma induced pulp necrosis, which can lead to discoloration, and also various exogenous sources like food substances, etc. Right? So, to summarize all the causes of this tooth discoloration, we have decomposition of pulpal tissue, trauma, hemorrhage, calcific metamorphosis, even filling materials, obturating materials, aging, iatrogenic considerations, and also we have this amalgam blues, which is different from amalgam tattoo. Amalgam blue is because where you have this amalgam restorations when the corrosion products of amalgam penetrate into dentinal tubules, the margins around the restoration have this bluish tinge appearance, which is called as amalgam blue. And we have this table 21.1 where they have mentioned or given us various colors of different types of discoloration. You can just have a look just for understanding. And I don't think it's really mandatory to memorize all these colors except for few, like for example, you have tetracycline staining, right? Which appears to be brown, gray, or black. Anyways, we're going to discuss about that later. And also, we have this pulp necrosis. That's very few among these can be remembered, but not the entire list. Okay, so that's in brief about your discoloration. And now, coming to the core topic, bleaching. So, bleaching is as such nothing but trying to minimize or trying to reduce the intensity of a stain. So far I've seen different types of discolorations and causes, right? So, the basic concept here is any stain is basically an organic structure. It's a complex organic molecule, so which absorbs and which reflects more amount of light. So the concept here is we're trying to break this complex organic molecule or chain, or we can consider that as rings. Complex organic rings are broken down into carbon chains or a simple molecule so that they reflect less amount of light. Only once they reflect less amount of light, the stain appears to be discolored clinically. So that's the concept which we're trying to follow. And to break these organic structures, complex structures into simple structures, we have various bleaching agents like hydrogen peroxide, carbamide peroxide, sodium perborate, and various OTC products like over the counter, like we have this Colgate White, we have various other chewing gums which claim to be containing a few percentage of this chemicals which help in breaking down these complex molecules into a simpler one so that there will be less light reflection from these stains, thereby minimizing the discoloration, right? So that's the basic concept on which the entire bleaching works. Now let's go through in brief various agents which are used for bleaching initially, and then we'll proceed with various procedures like we have bleaching techniques for vital teeth, non-vital teeth. Again, in each technique we have this in-office and at home techniques, right? So we have totally four. So we'll discuss them in detail and also the various problems associated with these stainings, especially resorption, stain. We have this hypersensitivity, so even they are very important. Right? And at the end, we'll focus on how to manage a case of tetracycline, because tetracycline stains are really resistant to all these bleaching techniques. And also we'll briefly focus on microabrasion, macroabrasion, and also the composition of McKean solution, what is modified McKeans, etc. Only the key points pertaining to that, right? I hope you're doing good and you have any issues with streaming or anything, or if you want me to modulate or alter my voice, do let me know. Hi Tanu, hi Preeti and Ramesh. Okay, then in that case, see that you can, I mean, you have this customized notes with you so that you can enter various key points. Okay. Ashina, network seems to be fine today. Yes, Gina and Alvin, sure. Okay, then we'll proceed. So first we have the definition formality. So bleaching may be defined as lightening the color of a tooth through application of chemical agent to oxidize the organic pigmentation in the tooth. And we have various bleaching agents like we discussed previously: hydrogen peroxide, sodium perborate, carbamide peroxide, and OTC or over-the-counter agents like where you can go and buy, pharmaceutical shop, pharmacy. Now coming to hydrogen peroxide. So hydrogen peroxide used in dentistry has a concentration range of 5% to 35%, and 35% concentration hydrogen peroxide weight by volume is called as superoxole. Superoxole is 35% weight by volume hydrogen peroxide, whereas perhydrol, it's not mentioned here, but perhydrol, it has a concentration of 30%, right? 30% weight by volume hydrogen peroxide is called as perhydrol, whereas superoxole is 35% hydrogen peroxide weight by volume concentration. So the concentration range used here is between 5% to 35%. And mechanism of action, as we have discussed previously, hydrogen peroxide has a very low molecular weight, penetrates dentin, releases oxygen, and breaks the carbon double bond into single bonds, and as a result, lightens the stain. And properties, as such, need not focus on all the properties, but it has very short half-life or a very short shelf life, and it has to be stored in a dark container, and the shelf life is approximately 3 to 4 months, And the amount of H2O2 which is required for any clinical procedure of bleaching is around 1 to 2 ml only, right? And also, hydrogen peroxide can be used alone or mixed with sodium perborate in paste form for use in walking bleach technique, which we'll discuss later, right? Non-vital bleaching technique. And hydrogen peroxide concentrations ranging from 3 to 7.5% are used for home bleach. Just mention these points or make a note of these points, right? So hydrogen peroxide, when used alone or mixed with sodium perborate, is used in walking bleach technique. And in home bleach technique, we usually use a low concentration hydrogen peroxide, like range 3 to 7.5%. Okay, so that's pertaining to hydrogen peroxide. Now coming to sodium perborate. Sodium perborate is a stable white powder normally supplied in granular form. It's available in three forms based on the oxygen content: sodium perborate monohydrate, trihydrate, and tetrahydrate. There is nothing like di, but there is mono, tri, and tetrahydrate. So mechanism of action, so sodium perborate releases on mixing with water or mixing with superoxide, that is 35% hydrogen peroxide, releases sodium metaborate, that's not so significant, but hydrogen peroxide and oxygen are being released. So ultimately, sodium perborate releases hydrogen peroxide. And it's also mentioned that when sealed in pulp chamber, sodium perborate oxidizes and discolors the stain slowly, continuing its activity over a long period of time. This procedure is called as walking bleach technique. So we'll discuss all this home bleach, walking bleach, all these techniques later, right? And next, we have discussed so far about hydrogen peroxide. Next, we have discussed about sodium perborate, and now we have something called as carbamide peroxide. So this carbamide peroxide on decomposition releases 3.5% of urea and 6.5%, I'm sorry, 3.5% of hydrogen peroxide and 6.5% of urea. This is very important, right? So carbamide peroxide, it is used in a concentration range of 3 to 45%. 10% carbonate peroxide, which is commonly used, decomposes to form 3.5% H2O2 and 6.5% urea. Urea maintains high pH and potentiates the action of hydrogen peroxide. That's very important. Okay. Now, so the most popular commercial preparations have a concentration of 10% carbamide peroxide. And also, along with these agents, we need some vehicle to carry them, right? So we have various vehicles like glycerin or propylene glycol, sodium stannate, phosphoric or citric acid, or flavoring agents, right? And some preparations contain carbopol, a water-soluble polyacrylic acid polymer, which is added as thickening agent, which prolongs the release of active peroxide and improves the shelf life. So carbopol is a water-soluble polymer which is added to improve the shelf life, right? And apart from these bleaching agents, we have over-the-counter bleaching agents. We have these images given here: toothpaste, chewing gums, bleaching pins, right? So they have very low concentration of these bleaching agents, and they are used primarily for removing extrinsic stains, mild extrinsic stains only, right? So these are some of the bleaching agents which we commonly employ in our profession. Now, coming to mechanism of bleaching, which is very, very important. I mean, all the mechanism of bleaching is mentioned in a flow chart in box 21.2, where it's mentioned that this bleaching action is basically a redox reaction. So it's basically a redox reaction where your bleaching agent, that is your hydrogen peroxide, acts as an oxidizing agent. It's an oxidizing agent which releases electron, whereas your complex stains, they're reduced, they accept electrons, and then there is breakdown of their bonds, and slowly, gradually, there will be lightening of stain, right? And so this mechanism of bleaching, which is a redox reaction, where the tooth is a reducing agent and the bleaching agent is an oxidizing agent. Please make a note of it. And these oxidizing agents, they release oxygen, oxygen free radicals, and these break down the complex molecules or convert the larger stain molecules into smaller ones, and as a result simple molecules are formed, and these reflect less light or they become colorless. So this is the mechanism of bleaching in brief. And also remember, while discussing this carbamide peroxide, we mentioned that 10% carbamide peroxide releases 3.5% hydrogen peroxide and 6.5% urea. So the pH of urea is 8, and which potentiates the action of hydrogen peroxide, and it maintains the alkaline environment, right? Just make a note of that point. Okay. Yeah, and also remember the pH of hydrogen peroxide, it's in the range of 9.5 to 10.8. 9.5 to 10.8. Now, after going through the mechanism of action in brief, it's very much important to understand the various factors which affect bleaching. So, surface cleanliness, concentration of peroxide, we'll just go through these factors in brief and note down only key points. So first, if you see surface cleanliness, obviously the surface has to be clean, free of plaque and debris before bleaching procedure is initiated, or else there will be a less efficacy of these bleaching agents, right? So surface cleanliness is very important, and concentration of peroxide is also very important. And also remember, in-office technique or bleaching techniques which are performed in dental office, the concentration of peroxide used is obviously higher. And we have this home bleach or walking bleach technique which are performed at home, or a walking bleach. So these have concentrations of peroxide which are comparatively low, 3 to 10% or 7% as we have seen previously. And also we have something called as shelf life. Obviously remember, the greater the concentration of peroxide, the greater is the efficacy of the bleaching agent, or the bleaching, right? And then you have the shelf life. So as we have discussed previously, hydrogen peroxide has very short shelf life. It has to be stored in a dark container. If you have ever seen any hydrogen peroxide bottle in your hospital or in your college, it will be stored in an amber colored bottle, it tightly packed and stored in a cool area, and it has a very short half-life, or shelf life for that matter, a matter of few weeks or months, whereas carbamide peroxide on the other hand has a shelf life of years. So shelf life, carbamide peroxide is more stable and has a shelf life of 1 to 2 years, whereas hydrogen peroxide has a shelf life of few weeks only. And coming to temperature, this is very important. The reaction gets doubled with an increase of 10 degrees centigrade. So we have this thermo-catalytic procedure where in office we use either light or heat in order to accelerate the action of these bleaching agents. So for every 10 degrees centigrade rise in temperature, the bleaching efficacy almost doubles. But remember, the temperature should not exceed 60 degrees. So the temperature is 52 to 60 degrees, which is being used in the thermocatalytic process. If it exceeds beyond that, there will be pulpal damage, right? Remember that. So this is of importance, temperature in office bleaching. And increase in temperature accelerates the release of oxygen free radicals. The reaction gets doubled with an increase of 10 degrees centigrade. However, an increase in temperature to an uncomfortable level can lead to pulp damage, as we discussed. And coming to pH, hydrogen peroxide is active in alkaline pH. The optimum pH for hydrogen peroxide ranges from 9.5 to 10.8. You need to memorize these values, right? And then time or concentration. So time, so with increase in time, the bleaching effectiveness also increases, but it should not be too prolonged, or else there can again be porosities, or there can be weakening of tooth structure, or there can be pulpal damage. And sealed environment. So sealed environment also plays a role in affecting the bleaching. It's especially true in case of non-vital bleaching, where you place a bleaching agent in the chamber of the pulp and then you seal it, right? So when it is sealed, hydrogen peroxide in the access cavity maintains the required concentration for active bleaching. So sealed environment also promotes bleaching. And we have various additives like glycerin, glycol, or toothpaste like materials in order to increase the viscosity of bleaching material. And these agents may reduce the efficacy of bleaching material, right? So just keep these points in mind. And finally, other factors like age of patient, initial color of tooth, gender may also play a role in bleaching process. So these are various factors which affect bleaching. So notably, try to remember these values of the concentration of H2O2, shelf life, temperature, pH, etc. Right? So this completes various factors affecting bleaching. So we'll just take 2 minute break, and then we'll proceed with the classification of bleaching procedures, and we'll go into the techniques in detail, right? Yeah. And hope you're doing fine. So you want me to alter the pace, just let me know. We'll modify that accordingly. Ashwin, I say it's miracle. Okay. Hi, Sashank. A very good evening. Hi, Anovali. Yes, Kinza, do a video on GIC, please. You have only done its setting reaction. Yes, Kinza, because I felt like that was the area where students, I mean, we all often get confused, right? So I just wanted to decipher that and simplify that setting reaction. Anyways, I'll definitely consider. Sure. Hi, Jaffiz. Hi, very good evening. Yes, LA. There is no necessity to use LA. First of all, it's not a painful procedure, right? So why do you want to even think of LA? Hi, Sadhana. A very good evening. So please tell me what point to wrote in notes. I mean, to write in notes. That's what I've been telling, right? I've been focusing on few points: pH, values, temperature, right? Concentrations. So you can just make a note of all these points. I mean, in fact, I'm not going through each and every line of the text. If you can observe, I'm just only going through important points, right? Only the key points. Okay, shall we proceed then? Right. Okay. So coming to the classification of bleaching procedures, we have this intracorneal and extracorneal bleaching. Intracorneal bleaching is usually obviously done for non-vital teeth or pulpless teeth. Extracorneal bleaching for vital teeth. So intracorneal is also called as non-vital bleaching. Extracorneal bleaching is also called as vital bleaching. So intracorneal, non-vital bleaching or bleaching of endodontically treated teeth, and extracorneal is vital tooth bleaching. So each one has again two modifications or components, like we have intracorneal bleaching, walking bleach technique, or in-office thermo-catalytic reaction or bleach technique. In extracorneal also we have at home and in office. So we'll start with intracorneal bleaching first. We'll only briefly go through the procedure, but we'll try to grasp as many important points as possible. And so coming to walking bleach technique. So intracorneal bleaching, we have walking bleach technique and in-office thermocatalytic bleach. There were several questions in regard to this. They were asked several times. Walking bleach technique is, so they'll be giving you various options like intracranial bleach, extracranial bleach, vital bleach, non-vital bleach. You should be able to make out, right? So walking bleach is a intracranial non-vital bleaching technique, right? So walking bleach technique, if you observe page 508, they have simply given in form of illustrations where in case of walking bleach technique. So before that, let's go through the indications and contraindications of walking bleach. So obviously, indications are those where only the intra part or internal part of the tooth is affected, like when the dentin is discolored or when there is an issue with the pulp chamber. So something which is related intracoronally. So only those are being treated by using this walking bleach technique. Whereas when you have the superficial stains or loss of enamel or any kind of fractures or extrinsic kind of stains, they are not addressed by this technique, obviously, right? So if you observe the indications and contraindications, indications: discoloration of pulp chamber, dentin discoloration, and discolorations not amenable to extracorneal bleaching or which cannot be treated by extracorneal bleaching. Whereas contraindications: superficial enamel discoloration, defective enamel formation, loss of dentin, presence of caries, discolored composites, right? So indications and contraindications are very important. Coming to walking bleach technique, if you observe, it's clearly mentioned that what we do in case of walking bleach, just follow the figure 21.9. So page 508. Internal staining of dentin caused by remnants of obturating material in the pulp chamber as well as materials and tissue debris in the pulp hole. Always they mention that when you're trying to obturate, care has to be taken that the obturating material is removed till the level of root canal orifice or at least 1 mm beyond the orifice in order to prevent discoloration of the crown. Or else what happens is the obturating material, they contain these pigments, colored pigments, they can enter dental tubules of your crown and they can be a source of intrinsic discoloration, right? So that's the reason why obturating material has to be removed till the level of root canal orifice, or preferably 0.5 to 1 mm beyond the root canal orifice towards the apical part. So whenever there is internal staining, corneal restoration is removed completely, access cavity preparation is improved, and gutta percha is removed apically just below the cervical margin or the CEJ, corresponding CEJ. And always remember, root canal orifices and CEJ are almost at the same level. Next, pulp horns are cleaned with a round burr, and shaving a thin layer of dentin from the facial wall is optional and may be attempted at a later date. A protective cement bed, this is very important. So once you remove the cement in the access cavity, assume that this is a non-vital tooth. This is a root canal treated tooth where you're going for this walking bleach technique. So you remove the temporary material, you remove the oxidating material till the level of cervical margin. And then the most important thing here is you have to place a barrier. A barrier has to be placed sealing the floor of the chamber in order to prevent leaching of the bleaching agent beyond, or else there can be resorption, or else there can be numerous drawbacks associated with leaching of these bleaching agents, which we'll discuss later, right? So a barrier has to be placed on the pulp chamber. This barrier, we can use different materials like resin modified GIC, MTA, but MTA is more preferred, right? And later, a protective cement base is placed over gutta percha, not extending above the cervical margin. After removal of sealer remnants or materials from the chamber with solvents, a paste composed of sodium perborate and water mixed to a consistency of wet sand is placed. And if you remember, sodium perborate, it when mixed with superoxide, as we discussed previously, or when mixed with distilled water, releases hydrogen peroxide. And a temporary filling seals the access. So once you place this wet sand consistent, that is sodium perborate, is mixed with either distilled water or superoxide, and then it's placed in the pulp chamber and then sealed with a temporary. At a subsequent appointment, when the desired shade has been reached, a permanent restoration is placed. Acid-rich composite restoration can be done to the pulp chamber. So this is how we perform this walking bleach technique. So we'll remove all the contents of the pulp chamber, seal the floor with resin modified JIC or MTA, and then we place this sodium perborate mixed with distilled water or superoxide, and then seal the pulp chamber and recall the patient after a few weeks to see for improvement in any shade if necessary or if possible. And also it's mentioned that the maximum page 509. Seal the access cavity to thickness of 3 mm using an adhesive material. This is very important, 3 mm, right? And this ensures a tight seal around the margins and prevents the leaching of bleaching material. And also it's mentioned that mixed sodium perborate, as I said, sodium perborate has to be mixed with distilled water. In case of severe stains, 3% hydrogen peroxide can be used to form a thick paste in a clean dampened dish. In case of severe stains, you can use 3% hydrogen peroxide, or else we go for sodium perborate mixed with distilled water. And remember, this is very important. Page 509, left side. The maximum bleaching effect is attained about 24 hours after the treatment. 24 hours after the treatment. And the patient should return in 3 to 7 days, that is the time for second appointment, for evaluation of the result. If the shade is too dark, additional bleaching is necessary. If the shade is too light, the tooth should be permanently restored. And teeth that are bleached have a shade too light seem to revert to their former color after the bleaching, even though it appears to be too light. If in case it reverts back or comes back to its normal color, right? So that's pertaining to walking bleach technique. And however, you have a few important points here to note. All the non-vital bleaching is effective. A slight potential exists for cervical resorption, external cervical resorption, which we'll discuss later, right? And this cervical resorption has been observed mostly when we use thermo-catalytic or heat or light in order to activate these bleaching agents. The walking bleach or in-office technique that doesn't require the use of heat is preferred for non-vital bleaching. And remember, to reduce the possibility of resorption immediately after bleaching, that is this external cervical resorption, a paste of calcium hydroxide powder and sterile water are placed in the pulp chamber. You can just make a note of that point. So to reduce the possibility of resorption immediately after bleaching, a paste of calcium hydroxide powder and sterile water are placed in a pulp chamber. Also, sodium perborate alone rather than in conjunction with hydrogen peroxide should be used as primary bleaching agent because hydrogen peroxide is too powerful to use and it can lead to these negative effects as we discussed. Although sodium perborate may bleach slowly, it is safer to the tooth. And periodic radiographs should be obtained after bleaching to screen for cervical resorption, which generally has its onset 1 to 7 years. So there has to be periodic follow-up. So that's pertaining to this bleaching technique and some unwanted effects associated with this walking bleach technique, right? So the agents used are sodium perborate. In case of severe stains, you can use 3% hydrogen peroxide. Now, moving on to bleaching of endodontically treated teeth in office. So far we have seen this walking bleach technique, but now we'll be seeing this thermo-catalytic reactions or in-office technique where we use heat and light or thermo-catalytic bleaching. Thermo means heat, catalytic. So heat catalyzes or increases or accelerates the action of your bleaching agents. So for this, we use 30% hydrogen peroxide. In case of your walking bleach, we are using sodium perborate or 3% H2O if necessary. But here we are using perhydrol. Superoxole is 35% hydrogen peroxide, 30% hydrogen peroxide is perhydrol, and 30% H2O is used in case of bleaching endodontically treated teeth in office. So after preparation, again the procedure remains the same. After preparation of tooth as previously described, a loose mat of cotton is placed on the labial surface and another cotton is placed in pulp chamber of the tooth. The loose cotton mats are saturated with 30% hydrogen peroxide. The solution, so you just place a cotton pellet inside the pulp chamber, drop or saturate that with 30% hydrogen peroxide, and then the solution is activated by exposing it to light or heat or both using a powerful light source. The tooth is subjected to several, usually 5 to 6 minute exposures, and bleaching solution is replenished at frequent intervals. On completion of bleaching process, a pellet of cotton moistened with H2O2 and sodium perborate is placed in the pulp chamber and sealed till the next appointment. So that's the difference we have between the walking bleach and this in-office thermo-catalytic bleaching. So in case of in-office thermo-catalytic bleaching, we place cotton dipped in hydrogen peroxide 30%. We then use heat and light, and then before closing the tooth or before sealing the tooth with the temporary, we load or we saturate the cotton with H2O2 and sodium perborate. Sodium perborate and H2O2 mixed together, and they are loaded in your cotton pellet. They are placed in your pulp chamber, and then they are sealed. An alternative, okay, that's all fine. So it's mentioned that H2O2 is added to cotton. As I said, we have to have this loose mat of cotton which is saturated with H2O2. H2O2 is added to cotton every 5 minutes because once you add cotton, once you add this hydrogen peroxide, subject that to heat and light, so there is release of oxygen-free radicals and its efficacy decreases, right? So for every 5 minutes, H2O2 has to be replenished. H2O2 is added to cotton every 5 minutes during bleaching, and the technique can be used by themselves or can be used in combination with walking bleach. So we can use both walking bleach and thermo-catalytic bleach in combination for effective bleaching or for effective reduce in the discoloration of a tooth, right? And also they have mentioned few studies here. I don't think that's very important, but it's imperative that a sealing cement like RMGIC is placed over the exposed root canal filling to prevent leakage and penetration of bleaching material in an apical direction. Okay, and coming to adverse effects of these intracorneal bleaching, this is very important. We have external root resorption, chemical burn because hydrogen peroxide as such has this ischemic effect on mucous membrane. If you remember, in perio also when we scale, have you ever used hydrogen peroxide to remove stains? So they used to give us hydrogen peroxide also, and they also used to exercise caution, especially when using hydrogen peroxide. The moment it comes in contact with soft tissue, there will be chemical burn if you ever observe. So there will be ischemic effect and there will be chemical burn, whitish layer formation, especially on the gingiva. So there can be chemical burn, external cervical root resorption, or there can be, even most importantly, pertaining to respiratory treatment, inhibition of polymerization of composite. So that's the reason why they suggest not to go for composite restoration immediately after bleaching procedure. If at all you're planning for composite restoration, you have to wait for 1 week after bleaching, or else what happens is these oxygen-free radicals, they inhibit polymerization, and there won't be effective resin tag penetration into the microporosities, thereby decreasing the bond strength. Or if you're planning to do composite immediately, then you need to clean the cavity, the bleached surface, with ascorbic acid. It's mentioned sodium ascorbate, which is buffered form of vitamin C that contains 90% ascorbic acid to 10% sodium. So that has to be used because it's an antioxidant. So we have an alternative here. So various adverse effects include external root resorption. So there have been reports of external cervical root resorption following intracorneal bleaching procedures. This is probably due to diffusion of hydrogen peroxide through unprotected dentinal tubules, leading to resorptive changes in the periodontium. Right? And also we have chemical burn, superoxide, which is 35% hydrogen peroxide, is highly caustic in nature and can cause chemical burns. Hence, gingiva must be protected with petroleum jelly, ora base, or cocoa butter. And inhibition of resin polymerization. The residual oxygen following bleaching procedure inhibits polymerization, as we discussed previously, and decreases the resin tag penetration into decreases resin tag formation, thereby decreasing the overall bond strength. So sodium ascorbate, this is very important, make a note of it. Sodium ascorbate is buffered form of vitamin C that consists of 90% ascorbic acid buffered to 10% sodium, a powerful antioxidant useful in eliminating residual oxygen following bleaching, right? So this is pertaining to intracorneal bleaching, right? I hope you're able to follow what we have been discussing so far. If you have any questions, do let me know. We'll just take 2-minute break and then we'll proceed with extracorneal bleaching, microabrasion and macroabrasion. Hi Praveen, good evening. Jaffies, can you tell us the names of chromophores used in laser bleaching? I'm not aware of these chromophores, Jaffies. I'm not aware. If you want, I can just find it and let you know. Pooja, hi. Composite, we use visible light. Visible lines, visual light of wavelength 400 to 480 nanometers, usually in that spectrum of electromagnetic radiation. I'll just make a note of that question, chromophores. Let's see if I can find out. Okay. Okay. In that case, we'll proceed, right? Fine. So extracorneal bleaching, we have vital tooth bleaching. So we have again in office at home. So at home we have this tray, and in office we use this thermo-catalytic. I mean, if anyone of you have ever undergone this extracorneal bleaching, or if you have ever done this, it will be simple for you to visualize while we are discussing simultaneously. So bleaching of vital teeth in office. So obviously remember the concentrations of hydrogen peroxide which are used in office are always higher than those which are used at home. Okay, and bleaching of vital teeth, 35% hydrogen peroxide solution is used, which is commercially available in form of solution, in form of gel, so that it will be better. I mean, we can have better control over the placement, and this may involve application of heat and light to activate the bleaching agent, hence called as thermo-catalytic bleaching. So it's mainly indicated in case of mild fluorosis and tetracycline stains, but not in case of severe stains, because severe stains only we can lighten, but we cannot completely eliminate the discoloration, right? And procedure, I mean, if you have ever done, we have something called as gingival barrier. So it's a light cure material. So we have, I mean, I've used it once, I've done it once during our post graduation. So we just, I mean, once in the sense, we do many bleaching cases, but this form of extracorneal vital tooth bleaching, I could do only one case where we place a gingival barrier. We have some blue color material with syringe consistency. We place all along the gingival. I mean, you have this gingival margin in scalloped fashion. So we'll try to cover that gingiva with your syringe material, and that can be light cured. So you can light cure it so that it stays over there, sets, and it acts as a gingival barrier, preventing damage to your gingiva. And then what we do is, isolation is all mandatory. So isolation is done, and then you place gingival barrier. And then what you do is, you after prophylaxis all will be done before itself. So we use this gel consistency. So this 35% hydrogen peroxide is available in form of gel. We have this powder and liquid which we need to mix, place it, neatly adapt it onto the surface of the labial aspects of the tooth which all are required for bleaching. And then we wait for 20 to 25 minutes. I mean, we place it and then we have this light source, a powerful light source for a duration of 20 to 25 minutes but not exceeding 30 minutes. So that way so that completes one cycle. So we can do a maximum of one cycle in one appointment, and then we'll see for changes or improvement in color later. If at all necessary, we call for a second appointment. So usually this kind of extracorneal bleaching, it's more effective as we're using more high concentration of H2O2, and moreover, I mean, we can even evaluate the change in color in single appointment itself, unlike the previous ones. So what we do is, initially before starting all these procedures, we evaluate the shade of a tooth, and then we'll try to compare the shade afterwards. So we'll try to take a shade. Initially, if I have come for bleaching, we'll take a shade first, we'll take a pre-op photograph, and then we'll try to compare this pre-op with post-op. So that's how we proceed with vital bleaching technique. So we use 30 to 35% hydrogen peroxide, and so all these gingival barriers are done, and this is very important. The temperature is very important. So temperature is, it should not exceed 52 to 60 degrees. Just make a note of this point. Apply heat with a heating device or a light source. The temperature should be maintained between 125 to 140 Fahrenheit or 52 to 60 degrees centigrade, right? And also remember, the treatment time should not exceed 30 minutes even if the result is not satisfactory. And remove the heat source and allow the teeth to cool down for at least 5 minutes. And then this is also very post-op instructions, very important. After you complete bleaching, dry the teeth, polish them with a composite resin polishing cup, apply neutral sodium fluoride gel for 3 to 5 minutes. So fluoridating agents are very important. Apply 3 to 5%, I'm sorry, neutral sodium fluoride for 3 to 5 minutes. Neutral sodium fluoride. And then instruct the patient to use the fluoridants daily for 2 weeks. Any bonded restoration on bleached surfaces should be postponed by 7 to 10 days. If you're planning for composite, at least wait for 1 week to 10 days. So that's pertaining to vital bleach technique in office. I'm sorry, where the concentration of hydrogen peroxide used is 35%, 30 to 35%. And then you have this laser or light assisted power bleaching. So laser also acts as a source of light and heat. So dental lasers and other powerful light sources can be used in order to enhance the bleaching action. So these light curing systems, they generate heat which rapidly dissociate hydrogen peroxide, potentiating bleaching effect. We have this nascent toxin. So the concept always remains the same. The basic mechanism of action remains the same, right? And also, it's mentioned in clinical note that polymethyl methacrylate restoration. So we have these temporary restorations which are made with acrylic. Remember, make a note of it. Polymethyl methacrylate (PMMA) restorations exhibit yellow-orange discoloration on exposure to carbamide peroxide. For this reason, temporary crowns should be made from bis-acryl materials rather than polymethyl methacrylate crown and bridge resin if exposure to carbamide peroxide is anticipated. If you're planning for bleaching using carbamide peroxide, temporaries which you give before should be made of bis-acryl materials rather than polymethyl methacrylate. Just make a note of this point. And also, the most common complaint which we hear after vital bleaching technique is tooth sensitivity, isn't it? We have this dental hypersensitivity, right? So this tooth sensitivity is because this hydrogen peroxide, because it has this low molecular weight, penetrates into enamel and dentin and leads to this hypersensitivity. So the characteristic is thought to account for mild tooth sensitivity occasionally experienced during treatment. So that's pertaining to vital bleaching, which is done in office. And then bleaching of vital teeth at home, we have this tray fabrication. So tray technique where we take impressions, fabricate tray, and we have the specifications given for tray. The base of the cast should be trimmed to a thickness of 0.5 inch. And the reservoirs, we have this polymerized resin which is used for forming the tray, thickness of 0.5 to 1 mm. So all these criteria are mentioned here, including the pictures. You can just even go through the images, right? So upper and in page 514, figure 21.4. So upper and lower cast trim to maintain a base height of 10 to 12 mm. Reservoirs are formed on the labial surfaces of teeth so that there can be retention of your material. It's given here in the textbook. I've shared some images also. You can see. So with wax, they're adding up material. So what happens is when you fabricate a tray, reservoirs are formed on the labial surface, right? So reservoirs are formed on the labial surface. The margins of reservoir should end 1 mm short of free gingival margin in order to prevent irritation to the gingiva, right? So instructions to patient, we ask the patient to wear the tray for 4 hours for every session. 4 hours for every session. If there is more sensitivity, we ask the patient to decrease the duration. Results can be seen in 1 to 2 weeks, or it even takes 6 to 12 months if at all there is severe discoloration with this type of at-home bleaching. Okay. On basis of numerous research studies, carbamide peroxide bleaching materials seem to be safe. So the agent which is used is carbamide peroxide, which has or which releases low concentration of hydrogen peroxide, 3.5%. And so it's commonly advocated in case of at-home bleaching, vital bleaching. So on basis of numerous research studies, carbamide peroxide bleaching materials seem to be safe and effective. And also, it's recommended that only one arch to be bleached at a time. If a patient has problem with maxilla and mandible, so one arch at a time. In the sense, we'll first complete the treatment of upper arch and then we go with lower arch. Because once you complete the treatment of upper arch, lower arch, the mandibular arch serves as a standard or as a reference for comparing it with the upper arch. So it's recommended that only one arch be bleached at a time, beginning with maxillary arch. And bleaching the maxillary arch first allows the untreated mandibular arch to serve as a constant standard for comparison, right? And adverse effects of extracorneal bleaching, tooth sensitivity, because this is due to the permeation or penetrability of the bleaching agent into the tooth structure, either through micro cracks, resulting in transient pulpal hyperemia. So post-operative care using fluoridated agents. Also, we mentioned that we apply neutral sodium fluoride gel, or we can even advise patient like post-operative care using fluoridated morphines or amorphous. You have this ACP and CPP, right? Amorphous calcium phosphate and casein phosphopeptide, which are remineralizing agents, even they can be prescribed. And even there can be other adverse effects apart from tooth sensitivity, like there can be enamel damage. So bleaching action on enamel may result in erosive areas and increased porosity because of the caustic effect of hydrogen peroxide. And then there can be gingival irritation because of the ischemic effect or causticizing effect of hydrogen peroxide. And apart from this, there can be even mercury release from amalgam restoration. So these are some of the adverse effects associated with extracorneal bleaching: tooth sensitivity, damage to enamel, damage or gingival irritation, or release of mercury from amalgam. So this completes our intracorneal as well as extracorneal bleaching. Now we'll go through management of tetracycline stained teeth, micro and macro abrasion. Devasish, hi. Hi, Devasish. I request if you could please try and do some lecture for you students too. Yes, Devashish, you can just check out our channel. We have a lot many videos. You can just go through the previous videos also in our playlist. I mean, whatever we discuss, it's not just for PG orientation. Obviously, it adds up a lot of information to UG students as well. So that's what I believe in while I record my videos. That's what I have in my mind. Anyways, just go and check out the playlist, Devashish, and your feedback is always welcome. You can drop a mail at proudtobedentist@gmail.com for any feedback or for any further information. Sadhana, maximum sittings for this vital in office bleaching, one or two. It depends actually. It depends upon the intensity of the initial color and the patient satisfaction. The patient is not satisfied. maybe you'll have to go for second sitting as well. But as such, the limit hasn't been mentioned here. But single session, the duration should not be more than 30 minutes. If the patient is not satisfied or if satisfactory results are not obtained, then we can go for second sitting as well. I mean, based on my personal clinical experience, maximum of two. Yes, they will know. Page 513. Yes, Niharika. Okay, talking about polymethyl methacrylate. That's what I'm saying. I mean, the bleaching agent carbonate peroxide, when comes in contact with these PMMA materials, there can be this yellow-orange discoloration. So to prevent this discoloration, for example, you've done a tooth preparation in relation to one. You're given a temporary material or temporary crown, right? So patient wants bleaching to be done. So when you're going for bleaching in that context, the temporary which you are given should be made of bisacryl materials rather than PMMA materials. If it is made of PMMA material, whenever you do bleaching, there can be this discoloration, right? So that's what they mentioned in that point. NaF gel is indicated mainly in case of vital bleaching because you're using a very high concentration of 35% hydrogen peroxide. So to counter the effects of these caustic agents, we are advocating or we are applying clinically NaF, right? Anyways, after bleaching, we can always advise these fluoride mouth rinses or various fluoride remineralizing agents. Hi, Saranya. It's mentioned that bleaching agents penetrate through the micro cracks, or because hydrogen peroxide has low molecular weight, it can penetrate into the into the enamel of dentin, and it can cause transient pulpal hyperemia, which is in fact manifested as hypersensitivity. Hi, Jafis. You missed out about light source. I mean, we had one question regarding which light source and wavelength is used for composite. So in that context, I mentioned that we use visible light of a wavelength 400 to 480 nanometers, approximately 450 to 480, depends upon the light. So it's in the visible range, usually. Yes, Niharika, glad to hear that. And Saranya, hope I made you, I mean, hope I've clarified your question as well. Of course, you can do composite before bleaching. Yes, you can. But it's always advised to do after because you do composite and then you go for bleaching. What happens to the color of the adjacent teeth, right? They become lightened, right? So again, there can be shade discrepancy. So it's better if you can postpone your composite restorative treatments and do it after bleaching process, right? We have more clinically oriented questions here because I'm quite sure all of you are more concerned about your aesthetics, isn't it? Right. So we'll just proceed with a few miscellaneous topics like management of tetracycline stain teeth. So we have this classification, which is very important. Also, I've seen one question from this classification. So tetracycline discoloration classification given by Jordan and Boskman, page 517. First degree, second degree, and third degree. First degree, light yellow to light gray staining without banding. So there is no banding in case of first degree, only light color or light discoloration. Second degree, darker and more extensive yellow or gray staining, again without banding. If you find banding, that is third degree. So severe staining characterized by dark gray or blue discoloration with banding. So tetracycline staining, even they use 30% hydrogen peroxide or use carbonate peroxide, all these agents are not so effective. So they have advocated that labial veneers with composite resins or even porcelain veneer, full coverage or full crown restorations are indicated instead of devitalization. So they have tried many techniques in order to treat or manage cases with tetracycline, severe tetracycline stains. So they have finally come to a conclusion. The authors here personally suggest that labial veneers or any full coverage restorations would be of more beneficial rather than going for these other techniques. Teeth discolored by tetracycline may also be bleached to some extent with H2O2, but bleaching effect leaves something to be desired with regard to discoloration. Okay, and also they mentioned about the degree of discoloration depending upon the developmental stage of tooth. And minocycline has the ability to affect permanent. And remember, tetracycline staining is done when, we have this teratogenic effects if you remember. So, mother in a developing fetus takes tetracyclines, or when children take tetracyclines at a very young age, when the teeth are in developing stage, they can take up this tetracycline, bind with dentin. So, there can be intrinsic staining, exogenous, right? So we discussed all this in one of the classes video. So not only this, but even in adults, there can be tetracycline related staining whenever we intake, you have this minocycline, right? So minocycline is eliminated even from TAP, triple antibiotic paste, because of the same issue, because it can cause discoloration. Minocycline has the ability to affect permanent dentition even in adults due to its ability to form complexes with calcium in dentin. This is very, very important. Clinical note, page 517. Minocycline has the ability to affect permanent dentition even in adults due to its ability to form complexes with calcium in dentin. And also it's mentioned that destaining of the yellow color is most successful, whereas brownish teeth are least successfully bleached. That's based on clinical observation. And finally, you have microabrasion technique. So microabrasion technique, so Kroll and colleagues have described extensively microabrasion technique using Prema, which is an abrasive paste containing HCl, silicon gel, silicon carbide, and silica gel. The compound is polished on the surface of teeth using 10:1 gear reduction contra-angle handpiece. That's all fine. So just remember the composition of Prema, PREMA, which is an abrasive paste containing HCl, silicon gel, silica gel, silicon carbide. And also we have something called as McKean solution and modified McKean solution, page 518. Make a note of it. McKean solution contains one part of anesthetic ether, 0.2%, which helps in removing surface debris, that is cleaning, right? Increases surface energy also. And 5 parts of HCl, 36%, which helps in etching the enamel, and 5 parts of hydrogen peroxide, 30% per hydrol, which bleaches the enamel. So you have one agent anesthetic ether which removes debris, you have HCl which etches the enamel, and you have this hydrogen peroxide which bleaches the enamel. So one part of anesthetic ether, 5 parts of HCl, and 5 parts of hydrogen peroxide, right? And 0.2%, 36%, 30% respectively. And modified McKean solution, we use sodium hydroxide instead of hydrogen chloride. That's it. So modified McKean's comprises 20% sodium hydroxide instead of 36% HCl. Since sodium peroxide is highly alkaline, it dissolves calcium off the enamel at a slower rate. Hence, modified McKean's is considered to be slower but safer alternative to original McKean solution. So, modified McKean's, you have 20% sodium hydroxide instead of your 36% hydrochloric acid. So that's your microabrasion. You have this Prema liquid, and also you have this McKean's and modified McKean solution. Now, in case of macroabrasion, so we use these burrs, 12 to 16 fluted burrs or these diamond burrs, in order to remove the surface debris or for gross removal of the stain, but care has to be taken not to over reduce the tooth. In macroabrasion, 12 or 16 fluted composite finishing burr or a fine grit finishing diamond in high speed is used to remove the surface defect. And once you are done with removing this gross surface defect, 30 fluted composite finishing burr is used to remove any striations. Remember, the lesser the number of flutes, 12 to 16, it's used for removing more amount of bulk. Finishing, whereas polishing is done with higher number of flutes like 30 or 28, so that there will be minimal removal of material, but there will be much better polishing or smoothness being created because of this higher number of flutes. So 12 or 16 fluted or fine grit finishing diamond to remove the surface defect, 30 fluted composite finishing burr to remove any surface striations which are created in the process of the previous procedure. So in fact, microabrasion and macroabrasion can be used together. First, we can go for macroabrasion to remove the majority of the defect, and then microabrasion to remove these finite details or to improve the finite details or to remove these discolorations, right? So this is in brief about micro and macroabrasion. So try to focus on the solutions, the composition, and also the diamond flutes or which are used in case of your macroabrasion, right? So this is in brief about bleaching. So discoloration and bleaching. So you can expect several questions, right? And also we'll have extensive discussion, extensive MCQ discussion from this topic tomorrow. So we'll frame some MCQs, 10 to 15, and we'll share. I will have some discussion. And in the process, we'll try to learn more and more topics. I mean, we'll try to elaborate on the same topic tomorrow also, right? And it's good to see that you're all still live in spite of such a relatively boring session, isn't it? Okay, Pooja, you have network issues, but it seems to be streaming fine here. Hi, Mariam. Light source. Light source used means you're talking about the wavelength. We use visible light only, or even laser can be used. Oh, Pooja is standing in balcony for network. Okay, be careful. Don't lean too much. Ashina, it's really wondering. I'm really wondering why your network is fine on your side today. It's breaking for everyone else except you. Hi, Jaffies. Glad to hear that you're a PG, Endo PG. Oh, wonderful. Yes, Jaffies. Drop a mail at proudtobedentist at gmail.com, right? Or you can drop a mail at sinavinkumar56 at gmail.com. You want anything pertaining to Endo, you can just contact me, right? sinavinkumar56 at gmail.com. Yes, Jaffies, glad that you joined us live and thank you so much for your feedback. And which college are you from, Jaffies? Yes, Bernice, repeat the bar flutes 12 to 16 to remove the surface defect, right? And 30 flute in order to finish off or in order to reduce the striations which are created as a result of this 12 to 16 fluted bars. Now Ashina started giving instructions to everyone. Reopen the app. Good. Yes, Alvin. Hi, Saranya. It's a good question. We don't prescribe toothpaste based on fluoride content. And recently, I've seen one comment. I mean, some foreigner. I'm not sure, maybe from US or some other country. They have posted a comment saying that the comment was exactly more or less the same. The person is saying in the Facebook comment that my dentist has prescribed this material, some restorative material which has the potential to release GIC, I'm sorry, to release fluoride. So the person is saying that I don't want that rat poison. Fluoride is a rat poison. I don't want to use that rat poison. Any holistic dentist, please respond and tell me the right treatment. So that's the kind of notion few people have. If fluoride were a rat poison, of course, anything in high concentration is a poison, isn't it? So in that case, why do we have minimal effects or no effects so far, even with community water fluoridation, which was a grand success way back in 1950s or 60s. And even till today, we're using fluoride containing toothpaste. All the toothpaste do contain fluoride. And to answer your question, Saranya, it's not just about fluoride. We have various agents. I mean, it depends upon the necessity. For example, uh, in my opinion, any toothpaste is fine. We just need a third material between your tooth and your brush to reduce the friction and to facilitate and to have some foaming action. So any toothpaste is fine for general population. It's not based on brand. It's not based on one particular component that we prescribe. That would be totally wrong and false. Any paste, so basic function is to have this foaming action, right? And also, of course, this antimicrobials, fluoride content, they're all over exaggerated in my opinion. But if at all a patient needs a paste for a specific context, like for example, you have hypersensitivity, then you have this desensitizing paste, or you have different paste based. For example, the patient needs whitening to happen. You have this OTC products, just we discussed now. So it depends upon the individual need. But in general, any paste, as long as you're using a paste, that's fine, in my opinion. Yes, Gina, glad to hear that. I know it's boring, but it's so nice of you that you're not revealing that. MCQs, Pooja, we'll have it tomorrow, right? Because I realized that this would be elaborate topic. So if I start with MCQs again, maybe it will become too lengthy, and I was not sure like how exactly this textbook discussion is going to happen. That's why I decided not to have this MCQ discussion today. So we'll definitely have it tomorrow, right? Tomorrow, day after tomorrow, I'll let you know through our group, update group. Yes, Regina, very interesting session. Glad to hear that. Why in different people with same diet, the continuity of the effect of bleaching persists a very different period of time? I didn't exactly get your question, Regina. You're talking about the relation of effectiveness of bleaching agent with time in different patients. Is that your question? I didn't exactly get you. Different people, same diet, continuity of effect of bleaching persists a very different period of time. I mean, to answer your question, I mean, there can be numerous factors like we discussed about the concentration of the agent we use, the control, I mean, the oral hygiene status of the patient, the prior situation of the discoloration. Yeah, that's what I'm saying, Regina. Some years for just some, it depends upon the intensity of the stain and also numerous other factors. If you say if that's the question, obviously the intensity of the stain is going to decide the treatment duration, isn't it? Greater the intensity, longer the time. And moreover, stains like this tetracycline, which have third degree or 3 degree, where you have this banning, it's even going to take months together or even years, as mentioned in your literature. Okay, Kochikode, you're from Kerala, Jafiz. Okay, glad to hear that. Nothing special mail for endo pages, but it's my personal mail. Sainavin Kumar 56 is my personal mail. I mean, I use it for personal purpose, not for academic purpose. Anyways, that's the reason why I give a separate mail ID so that we can have some personal interaction. I mean, you all are also welcome to mail at sainavinkumar56 at gmail.com. Sashina has become a pro in network issues. Yes, we are all amateurs. You are pro, definitely. Actually, I scolded toffee before starting this session. So it's quiet, it's not making any sound. Enzyme toothpaste. I haven't heard of it, Regina. What is that enzyme toothpaste? I mean, is the spelling right? Yeah, we'll have tomorrow morning, 5 o'clock as usual. Preeti, we'll have tomorrow morning, 5 o'clock. These techniques were used to prove it's not a miracle or it's not that I have these superior powers. It's all repeated practice. I have been going through it. And moreover, I have revised this topic previously while going through this public health dentistry week where we had this discussion. So, moreover, while explaining that topic to us, they made it so interesting. They explained all this. I still remember the years 1956 or 1955. Colorado and all, they have introduced this community water fluoridation. And moreover, it's my personal favorite, not just the community or public health industry, but remembering numericals and scientist names. I enjoy doing that. I mean, few of us have that fear for numericals, but I don't have that fortunately. It's not that I am superior or I'm unique. We all can remember, but it's only practice, repeated revision. That's making this possible. Come on, I'm not giving PG exam now, right? I've already given that 4 years ago, and I've been repeatedly revising. So obviously, it's not a miracle or it's not something which is superior. Okay, Gina, glad to hear that. Yes, Saranya, you're most welcome. And even during our high school, 10th and all, I used to enjoy remembering all these years. I don't know how, maybe, but I somehow I used to enjoy remembering all these numerical, like what happened in 1820, 1830, and also general knowledge was my favorite topic then. So maybe I had that propensity to remember these numbers and numericals. Yes, Gina. Yes, chronic coffee drinkers, they do have this extrinsic exogenous discoloration. That's true. Even I heard the same. Not just coffee, but also you have this non-veg food where you have this food discoloration. I mean, food color. You have this coloring agents being added. So even they can cause these extrinsic discolorations. That's true, Gina. Hi, hi, hi. Here comes our chief guest. Say hi. Say hi. Say hi. Hi. Mm. Toffee. Toffee. Show your face to everyone. Regina, yes, if patient is asking for how long his or her teeth will be white, what should we answer? Just asking this question. How long did you take to have this discoloration? I'm just kidding. So it depends on the intensity, right? So if you're going for it, depends on the technique also. Usually vital. I mean, if you're planning for vital bleaching, if it's a vital tooth, vital bleaching, part bleaching is going to be more effective, and you can complete off the treatment, or you can get the desired results in a less duration provided. It depends upon the pre-operative status. I mean, the initial intensity of the stone. So we can't give a standard time, but it's mentioned that it's a good question, Regan. In fact, I've seen that in literature. It's mentioned that the effect of bleaching usually lasts for 1 to 3 years. So that's pertaining to prognosis or the effect of bleaching. But as such, how long his or will be white? I mean, I think I answered your question in that case. 1 to 3 years, as per the literature. Yes, Prithvi, 1 to 2. It's mentioned as 1 to 3 in this textbook. Okay, Regina, I have no idea regarding that enzyme toothpaste. Is it a brand or is it a generic name? I have to just refer. Saranya, I haven't heard of that. Is it true that if you bite a raw brinjal, the tooth will become black? I never heard of it and I'm not really sure of it. Maybe it's a myth. I'm not exactly sure. Anyways, I'll see if I can find out. Okay, I'm just taking a screenshot of that question. Yes, Komal. You want that at 4 o'clock? Yes, tomorrow 5. We have morning 5 o'clock sessions on Thursday and Friday. So Priya has a smart answer. Answer until and unless she or he see her teeth in mirror. White. Okay. Yes, Toffee is in serious mood today. I scolded Toffee. I scolded her. Yes, Najni. Early? 5 o'clock. 5 o'clock is the best time. Yes, Prithvi. Right. Toffee. Okay then, shall we break? It's already 10:30. Again, we have to start at 5 o'clock tomorrow. Komal, you have college at 7 o'clock. Then maybe we should start at 3. Your college at 7? Really? Or you start at 7? You're talking about Turner Dental College, right? Turner Dental College. Okay. Right. So we'll break then and we'll have some MCQs from Endo as well as Conservative tomorrow morning, right? Tomorrow morning, 5 o'clock. We'll see you all live again. So it was again good seeing you all live and seeing you all stay live till the end of the session. It's really quite surprising. Okay, then we'll break. See you tomorrow morning. Good night. Have a pleasant sleep. Love you all.